Hello and welcome to this episode of sMater, a podcast by clinicians for clinicians, brought to you by Mater, an Australian leader in healthcare for more than a century. My name's Gillian Whiting.
And I'm Ash Bondelow, breast cancer clinical nurse consultant at Mater Private Hospital, Brisbane.
And we're coming to you from Meanjin, the land on which this podcast is being recorded. Today we are joined by Dr. Rebecca Moor, medical oncologist at Mater Private Hospital Brisbane and Mater Private Hospital Springfield.
Rebecca specialises in breast and thoracic cancers, and she has extensive experience in managing patients with a broad range of solid tumour malignancies and complex healthcare needs.
Beck also participates in clinical trials through Mater Research's Medical Oncology Clinical Trials Group and as the lead or associate investigator on a number of clinical trials focusing on breast and lung cancers.
Today she's joining us to talk about young women and breast cancer, pregnancy, fertility, preservation and beyond.
We are Mater.
We are Mater.
We are Mater.
This is sMater.
Rebecca, welcome to sMater.
Thank you.
Let's get a snapshot of breast cancer in young women in Australia at the moment. What's the incidence rate and is it becoming more common?
It is getting more common. So around 1,000 young ladies are diagnosed with breast cancer each year. So that's people under the age of 40 years. And if you take that back, that's about 3 ladies diagnosed with breast cancer under the age of 40 every single day. So these are often ladies who will have a poorer prognosis than older ladies who are diagnosed with breast cancer. They may have a more aggressive form of breast cancer and are more likely to carry genetic drivers like BRCA mutations, which brings into it a lot of specific concerns as well.
They are in a unique phase of their life at their childbearing years, women under 40. We do have a lot to cover here, but can you give us an overview of how this is all considered from a breast cancer and treatment perspective? So how we consider young women for their best treatments?
They may be young mums, they may not have had children yet. We're talking about treatments that may affect their fertility and all of that needs to come into play. So often we've got to do a lot of things very quickly when we're trying to commence their breast cancer treatment. So sometimes they may have just been pregnant, they may be breastfeeding. That can lead to a delayed diagnosis because there's lots of changes that are happening in the breast tissue at that time. And often people will just put it down to pregnancy-related changes or hormonal changes. So it's important to be aware that breast cancer does happen in ladies under the age of 40 and not to dismiss those symptoms. So these ladies are getting prompt investigation so we can get on to their treatment as quickly as we can.
Are there particular factors that you'd like GPs or other clinicians to keep an eye out for?
In terms of young ladies, so I think it's really important in people that do have a family history, so especially people who have known BRCA mutations in the family. Things like high-risk screening clinics are important. They may be entitled to be seeing a breast surgeon and having specific screening from an early age, so which can help diagnose these cancers early. Also, it might mean that they may be able to have prophylactic treatments, which can decrease their chance of developing breast cancer. But of course, that all depends on what stage they are in their life and where they are with their family planning. If they've had children, there's a lot of things that come into play.
How often do we see women who are pregnant who are diagnosed with breast cancer?
So pregnancy-related breast cancer occurs in 1 in 3,000 pregnancies. So it's actually the most common pregnancy-associated malignancy. And that's because there's lots of changes that are happening to the breast tissue during that time. And I guess that's one of, the most challenging sort of cases that we can find. So breast cancer in young ladies is complex. Breast cancer in pregnant ladies is extremely complex.
What's the connection there with mothers ageing, like we're waiting longer to have children. Is there a connection there?
Yeah, there certainly is. So we know that in ladies who have had their first pregnancy by the age of 20 or even 25, compared to ladies who are having their pregnancy or their first pregnancy after the age of 35, the incidence of breast cancer during pregnancy is much higher in those who are delaying their childbearing. And with our lives at the moment, everyone's getting busier. There's more females in the workplace, so we see it more and more common.
We still treat women who are pregnant with breast cancer. What measures need to be taken for these women to do so safely?
I think it's really something that's important for especially GPs to understand that these ladies, we can offer them treatment. It all factors on the type of breast cancer they've got, the gestation that they're diagnosed at. So we can even give things like chemotherapy during the second and third trimester. Ladies that can have surgery, there are treatments that are absolutely contraindicated, and so things like targeted agents, endocrine treatments, immunotherapy or HER2 directed treatments are all things that we would avoid during pregnancy, but we can do other treatments. So again, I think the most important thing is prompt diagnosis and getting those referrals in, and then coordinating their care. So often with a patient like this, a breast surgeon may even be on the phone to me as soon as they get the referral from their GP, just knowing that it's going to be a complex case, and we want to get the ball moving on their treatment as quickly as we can.
Yeah. We're in a unique position here at Mater. We are Australia's largest maternity service provider, and we have the Mater Mothers Hospital here on site. What difference does that make? And for those oncologists who don't have access to, the Mater Mothers Hospital here, or maybe in a more regional or remote setting, how can these oncologists achieve the same outcomes that we see here?
We are extremely fortunate here in terms of the scope of professionals that we've got. So in a case such as a young lady that's pregnant who's been diagnosed with breast cancer, we will have a huge team involved. And that ranges from the breast surgeon, the surgical nurses, medical oncologists, radiation oncologists who will probably be involved later, radiologists who are have that experience with interpreting studies in ladies that are pregnant, because it does impact on their breast imaging as well. And then across to specialist obstetricians, so maternofetal medicine specialists, specialist nurse midwives, psychology, social work. There is a huge team that needs to be involved. So it is more difficult in regional hospitals who, don't have a maternofetal medicine unit 50 metres across the road from where they're based. But I guess my advice would be to pick up the phone and call for help. So because, if you've never seen a case like this, it's important to consider the impact on your treatment regimens, how we give the medications, even planned interruptions in treatment to allow for a safe delivery of the baby, and then also monitoring and things as well. So there's a lot of different options that we have available for ladies who are pregnant and have pregnancy-related breast cancer. It's about having that team approach so that we can make sure that we're getting the best outcomes for the patient and for the baby.
The Clinical Oncology Society of Australia Fertility Preservation Task Force established the guidelines for fertility preservation for people with cancer in 2022. It highlights the importance of education for multidisciplinary team members, as well as pathways for referral of oncology patients to fertility specialists to discuss oncofertility options. In addition to this, it flags the importance of improving patient communication on fertility risk and cancer, and the resources that have been developed to introduce fertility preservation options to patients and their families.
Rebecca, can we talk about the patients who are diagnosed with breast cancer and still want to fall pregnant after their treatment? What factors are important for those women?
Yeah, so I guess in those ladies who have been diagnosed and still want to fall pregnant later, so whether they haven't started their family or maybe they've had one child and want to expand it further afterwards, again, there's steps that we can take to try and minimise the effect of the cancer treatment on their fertility. So that can be from things like cryopreservation of either eggs or oocytes, in which case they'll have a cycle of ovarian stimulation before they start their treatment, and to medications that will help shut down their ovaries during chemotherapy, to try and protect their ovaries and their fertility later on. And that all depends on, I guess, the drugs that we use, and the age of the patient as well. So the effect of chemotherapy on ovaries in a 25-year-old is very different to that in ladies who are maybe 38 or 39, in which case there is a very real risk with intensive chemotherapy for breast cancer that we could make them infertile after that treatment if we just sort of carry on as usual.
What about timing? And obviously you want to treat these things as soon as possible, but allowing extra time for collection of eggs and those kind of things?
Yes. So it does depend on the type of breast cancer, but again, it's one of those things where in a young lady, we know that we should be thinking about it. So often they may meet a fertility specialist before they even meet their oncologist, and that process really is time critical because it can depend on where they are in their cycle. So if we miss a certain window, then sometimes that delay can be greater. If they're on the pill, then again, just making sure that we can try and get them to see the fertility specialist so they have that option if that's something that they want. So it's often something that the breast surgeons will raise with patients, so they're at least thinking about it, and also they'll talk to the medical oncologist as well when they meet someone like myself. But it is very overwhelming when you've just been diagnosed with cancer, and the natural reaction to that is that I want to get into the treatment as soon as I can. And then we're talking about things like potential delays and weighing up the risk. But in general, in most cases, it's safe to delay for a couple of weeks to allow for that fertility preservation process to occur if that's something that the patient wants to consider.
We've spoken about fertility preservation prior to starting treatment. What about during treatment? What do we do to limit the impact of fertility?
Yes, so there's medications like goserelin or Zoladex, which is a monthly injection, which will commonly be given to ladies just before they start their chemotherapy and proceed on the way through chemotherapy as well. So if we're shutting off that cycle of the ovaries, then we can help protect them and fertility from chemotherapy.
Are there any side effects there?
Certainly. So you're essentially making a lady menopausal. So hot flushes, issues with sleep, aches and pains in the middle of chemotherapy as well. So it does add to potential side effects, but it is something that is really, really important to consider, and it's certainly one of our national standards that we expect in treating ladies with breast cancer who are young.
How successful are the fertility preservation measures?
Again, it depends on the patient's age. So there's far greater chance of success with a younger patient with a higher ovarian reserve than it is with someone who's, say, in their 40s. And we do have to be realistic with that as well. Sometimes they're hard conversations if you've got someone who's sort of 45 and, the chances of fertility preservation prior to chemotherapy, unfortunately, may not be that high. So it is something that we have to weigh up. However, in younger ladies, then it is very successful, and also it brings into play a number of considerations after surgery and when patients are on, especially on hormonal treatments for ER-positive breast cancer, about timing of breast cancer and timing of pregnancy, and when that may be safe.
A Swedish nationwide cohort study conducted between 2008 and 2017 investigated the long-term reproductive outcomes of women with breast cancer receiving fertility preservation. It found that although successful pregnancy after breast cancer is possible for those who undergo fertility preservation and those who don't, there was a significantly higher likelihood of live births and assistive reproductive treatments in women who underwent fertility preservation. For instance, 5 years on, the incidence of post-breast cancer live births was 19.4% among fertility preservation exposed women versus 8.6% among comparators.
How long should patients wait before trying to conceive? Is there a certain amount of time? And also, should they be prepared for any potential challenges in actually trying to fall pregnant?
So in general, we'd recommend at least 12 months pass before they start to explore the option of pregnancy. There are increasing studies that have proven that even in ladies with hormone-positive breast cancer, that you can safely interrupt their endocrine therapy for a lady to pursue pregnancy and breastfeeding, and they don't have any worse outcomes than other patients. However, it also depends on the type of breast cancer that they've had, so often, and the age of the patient as well. So if you've got someone that's very young, if they're in their early 30s and they've had an aggressive triple-negative breast cancer, you might be recommending that perhaps they wait sort of through the highest risk of recurrence sort of period in the first sort of 2 years or so. Before exploring pregnancy. In hormone-positive patients, again, it depends on the age, because if someone's 37 or 38, then that 2 years might have a really drastic impact on the chances of them having a successful pregnancy as well. So there's lots of things to consider, and often it's important for involval of a fertility specialist after as well, so that they're not trying for too long before they start having sort of escalated assistance with falling pregnant as well. But in general, it's certainly something that we talk to ladies about, and a minimum of 12 months.
Rebecca, we've had patients who have gone on to have children after their breast cancer treatment. How do different treatments impact on a woman's ability to breastfeed?
Well, I guess the most obvious one there is what kind of surgery they've had. So if a lady has preserved their breast tissue, then it's certainly possible for people to breastfeed after breast cancer. However, obviously, if they've had a mastectomy or reconstruction, then that's not the case. In general, we do have to stop things like endocrine or hormonal therapy for that period of time. So it's not only the pregnancy, but also breastfeeding afterwards as well.
Let's talk now about wellness and survival for young women with breast cancer in terms of a long-term approach to breast cancer care. What may young women need to be more aware of than, say, a woman in her 50s or 60s?
In women diagnosed with breast cancer at a young age, they've got far more time after their breast cancer diagnosis for those treatments to impact their general health. So certainly in terms of making a 30-year-old essentially postmenopausal, that can have great impact on their things like their bone health, so increasing the risk of osteoporosis, and that needs to be part of our long-term monitoring as well, in terms of making sure that we're looking after bone health and trying to prevent osteoporosis in later age. There's also things such as sometimes the hormonal treatments can increase the chance of high cholesterol, and so all of those other factors need to come into play when we're monitoring someone who's on endocrine therapy.
What is the current recurrence rate for women under 40?
Again, it very much depends on the type of breast cancer that they've had. But in general, in ladies who are diagnosed at a young age, their recurrence rate is actually higher. They can be diagnosed with more aggressive types of forms of breast cancer, and so naturally the incidence of recurrence in those cases is higher as well. And then also when you're considering the time that cancer has got to come back. A 40-year-old has a long expected lifespan, so they, potentially cancer can return 20, 30 years down the track, especially in forms of hormone-positive breast cancer.
What should GPs and other clinicians be looking out for as far as a breast cancer recurrence goes?
I guess the symptoms that I always warn my patients to be aware of, and I guess that I'd also want GPs to sort of think as red flags, would be sudden unexpected weight loss, so not with a new exercise regimen or things like that, but just weight starting to fall off, headaches and nausea, vomiting for no specific reason, and then also severe pain that's lasting more than 1 or 2 weeks, again with no specific trigger, and is bad enough to keep people awake. They're sort of symptoms that I would want to be investigated fairly quickly, so that we can look out for recurrence as well. It is also important to consider the phenotype or the type of the breast cancer that someone's been diagnosed with. With hormone-positive breast cancer, it's more likely to come back in lymph nodes locally or in bones. In triple-negative breast cancer or HER2-positive breast cancer, then we do see a higher incidence of things like brain metastases as well. I think we can also factor that in. If you've got a hormone-positive breast cancer patient with new headaches, we can really offer a lot of reassurance because it's incredibly rare for them to develop intracranial recurrence. But also when we're talking about the type of breast cancer, things like lobular breast cancer, which can recur in really strange patterns. So it might come back to mucosal linings. We can see it in the stomach. Again, things like that in terms of unexplained nausea. With the type of breast cancer, it is important as well.
There's clearly a lot of complications and diagnosing and treating young women with breast cancer. What are the positives going forward as far as treatment and recovery?
I think the biggest positive is that we're curing more ladies with breast cancer every year. So our treatments are getting better. There's lots of new developments, new medications that are coming through. So things like CDK4/6 inhibitors, immunotherapy, new targeted agents, antibody drug conjugates. We're getting more lines of treatment for these patients all the time. So I think there's a lot of hope in that space. There's a lot of research going on, and I think that's always important for patients to be aware of as well, because these new treatments are coming, and we always want to strive to do better in terms of what are the best outcomes we can get for ladies with breast cancer.
It's great to hear. Thank you so much for coming in and sharing your expertise with us today. Before we go though,
we want to introduce you to a little segment we call The Checkup.
So this is about finding out about Rebecca, the person, the human, as well as the medical expert. So Ash has 5 questions to ask you. Quick questions,
excellent.
Nothing tricky.
Rapid fire answers, please. What show best portrays your profession?
Ooh. New Amsterdam.
Good one. Who do you admire?
Probably my patients. I think our patients and our families continue to surprise and, touch my life every day. That's why I do what I do. So I think sometimes it's been very common where I've had a really rotten day or rotten week and a patient or the family said something and it completely changes your week and your day. So I think our patients.
Love that. If you had a day off today, what would you do?
Probably housework.
Oh no!
Wrong answer.
I want to. Probably something with my kids. So I'd be enjoying being a mum and being able to drop them off to school and pick them up.
How would you describe your handwriting?
My handwriting's good.
It is good.
I have, my mum is a teacher, so I lost my pen license in grade 4 and there was no going back. I had to be neat ever since then. So my writing is pretty good, I have to say, for a doctor.
It's excellent. If you could impart one piece of knowledge on a med student, what would it be?
Don't take your work home. Have something outside of work that keeps you going.
Great advice.
Beck, thanks again so much for joining us on sMater. For our listeners at home or in the car or having a well-deserved break between patients, thanks for tuning in.
Join us for our next episode where we continue exploring women's health.
See you next time on sMater.